Very good afternoon, dear colleagues and friends. We're all aware that obesity is assuming epidemic proportions in our country, and children are no exception. And along with that, there's a dual problem. On one hand, we have the problem of malnourishment and a stunted population subgroup, and on the other hand, we have a real an epidemic of obesity among children, especially in the urban centers. From surgery unit 2, we're going to present an interesting case of genetic obesity, which was managed by us. Dr. Vinu will present the case, and my colleague, Dr. Arun, who's a fellow in bariatric surgery, will discuss the case. Dr. Vinu.
Good afternoon to the respected faculty, to my seniors and my colleagues. Today I will be discussing an interesting case of an adolescent girl who was menaced with MC4R gene mutation and how the timely intervention helped her beating the odds. So she was a 13-year-old young female resident of Assam. She was initially evaluated in Department of Pediatric Endocrinology, where she was diagnosed to have a melanocortin 4 receptor gene mutation leading to the severe obesity, and along with that associated central diabetes insipidus. So for her severe obesity, she was referred to us with associated comorbidities of type 2 diabetes mellitus, hypothyroidism, hypocortisolism, and features of obstructive sleep apnea like severe excessive snoring and daytime sleepiness, and bilateral knee pain since 5 years of her age. So in the past, she had tried non-operative weight reduction measures like exercise and dietary modification, but she was not able to do the exercise because of her knee pain, and her because of the genetical component of this hyperphagia, her dietary control was unsatisfactory. So for her endocrinological complaints, she was already on prednisolone, desmopressin, thyroxine, and metformin. So on anthropometrical parameter assessment, she revealed an BMI of 77.5 kg per meter square with an excessive weight of 91.5 kgs, and along with that, truncal obesity was noted. On general examination, which was essentially normal, and there is no features of any syndromic obesity was noted, and rest of the systemic examination was within normal limits. So in the preoperative workup, we went ahead with multimodality approach, which include preoperative counseling by our bariatric team, including the patient and the family members, and along with that, specific bariatric surgery related investigations and optimization of the patient for the bariatric surgery. So in the preoperative counseling by our surgery team, the patient and the family members were clearly explained about the nature of the surgery that she is going to undergo. That may be a restrictive bariatric procedure or a malabsorptive bariatric procedure. Along with that, the surgical options like in restrictive procedure, laparoscopic sleeve gastrectomy, and in malabsorptive procedures, RYGB and one anastomotic gastric bypass. Along with that, pros and cons were clearly explained. And the patient and the family member were explained about the benefits of the undergoing the bariatric surgery, and specific surgery related complications are also explained. And it is difficult to define the expected weight loss of the patient at that time, like it is 100%. So we have explained about the weight loss around 60 to 80% will be seen, and the chances of the weight regain also clearly explained. So as she was a child, and along with the genetical component of this genetical mutation, there will be a component of the depression and low IQ. So she underwent a detailed psychological evaluation by our clinical psychiatry department, in which along with that all the patients who are undergoing bariatric surgery will routinely undergo psychological evaluation. So in which they will assess the intellectual function of the patient using intelligent test and neuropsychological assessment tools. By this assessment, the patient is having an IQ of around 80 to 90, which was in the average range. And coming to the behavioral assessment, in behavioral assessment, there are wide variety of maladaptive behaviors like excessive eating because of the hyperphagia, and there will be chances of depression, low IQ, depression and the fear. And along with that, in clinical interview, we will assess based on the structured clinical interview and clinical diagnostic interviews. And personality assessment, we will assess the patient genetical, environmental, and social causes of any personality issues will be assessed using personality assessment tool. By all this psychological evaluation, our patient doesn't have any component of the depression, and because of the genetic mutation, she had a component of hyperphagia. So as per our bariatric protocol, all the patients who are undergoing bariatric surgery will undergo detailed counseling by our dietitian, The perioperative period, patient will be put on very low calorie diet for around 2 weeks, which was around 600 to 800 kilocalories per day, in which it will help in decreases in the size of the liver and along with the decreases in the intra-abdominal fat, which will help us at the time of the surgery by easily mobilizing the liver and along with that clear dissection at the time of the surgery. Along with that, we can able to assess the compliance of the patient, because in the post-operative period we will be putting the patient on the clear liquid diet initially, then we will be shifting to the pure diet, then the patient will be gradually shifted to the regular diet. Along with that, we will be teaching about new eating patterns like slow eating and taking the meals in small frequent quantities. So in this case, this dietary counseling is so important because of the genetical component of the hyperphagia. So after the thorough counseling and getting consent for the surgery, we went ahead with the detailed biochemical assessment of the patient, which revealed a low vitamin D, which is common in bariatric patients, and poorly controlled diabetes mellitus. So on further investigation specific for bariatric surgery, her liver shows grade 1 fatty liver. Along with the fibroscan also suggests of non-alcoholic fatty liver disease. Fortunately, her sleep study suggests of mild OSA, and endoscopy was done to rule out any component of the hiatal hernia and reflux, which was found to be normal. So to summarize the case, she was a 13-year-old adolescent girl suffering from morbid obesity with genetic mutation and associated panhypopituitarian related comorbidities and morbid obesity related comorbidities with pain non-operative measures of weight loss. So our plan is to go ahead with a restrictive bariatric procedure, which is laparoscopic sleeve gastrectomy over a malabsorptive procedure, which is bypass procedure, because she didn't cross her growth spurt, so there will be a minimal impact on the growth of the child and there will be a minimal risk of malabsorption and nutritional deficiencies. So she underwent laparoscopic sleeve gastrectomy in October 2015, in which we routinely remove 3/4 part of the stomach along the greater curvature by creating a narrow tubular part of the stomach which was calibrated over the 36 French bougie. So after the surgery, postoperatively the patient was postoperative course was uneventful, and the patient was discharged on postoperative day 4. So in the regular follow-up, she had lost significant amount of the weight after the surgery. Along with that, significant improvement in the resolution of the comorbidities like diabetes mellitus, obstructive sleep apnea, and knee pain. However, after losing 43 kgs after the surgery, she gradually again started gaining the weight from 92 kgs to 115 kgs. So again, she was readmitted with the plan of management and weight regain, as the patient and the family members are also very keen to know the same. So on further investigation at the time of readmission, her hemoglobin was a bit low, and ultrasound abdomen suggests of a mild hepatomegaly with contracted GBV sludge, and a parambilical defect of 1.5 centimeter was noted. However, the most importantly, the endoscopy shows that normal postoperative anatomy, and there is no evidence of dilatation of the sleeve. However, barium swallow shows fundus was dilated and there is no hiatal hernia was noted. So she underwent a detailed counseling as previous, along with that the surgical options, in which the patient and the family members were clearly explained about the risks of revision bariatric surgery, as which is a bit more as compared to the primary surgery. And we have explained about the benefits of undergoing revision surgery, which is which include better weight loss and improvement in the quality of the life. So after the patient opted for the revision bariatric surgery, again she counseled about the surgery that she is going to undergo, that may be a bypass, re-sleeve, or a banding. So in that, we prefer one anastomotic gastric bypass because of its superior weight loss. So she underwent a revision bariatric surgery in December 2020. So at the time of the surgery, her liver was found to be cirrhotic and sleeve was dilated, and there is a small hiatal hernia was noted. So an intraoperative decision was made to do re-sleeve along with the concomitant hiatal hernia repair, and cholecystectomy and primary repair of umbilical hernia was done, and her postoperative course was uneventful and she was discharged on postoperative day 5. So her current status was she was doing well. She was quite active in her life. She was also pursuing her degree in BSc with a weight of 63 kgs with BMI of 28.2. She lost around 69 kgs of weight after the primary surgery and around 52 kgs after the secondary surgery with no impact on the growth of the child. As we can see here, there is a gradual increases in the height. So now I invite Dr. Arun to discuss about the literature part. Thank you.
Thank you, Venu, for a nice and comprehensive story of the patient. For embarking on the discussion, I'd like to talk about the existing prevalence of adolescent obesity and especially overweight children as well in India. As per the literature, the number was in around 16.3% in 2005, which increased to 19.3 in 2010. Although the data of 2015 suggests that we are second highest in absolute numbers after China as far as adolescents with overweight and obesity is concerned. This is about the existing prevalence of both overweight and obesity. But what is more worrisome to know is that the data released on this 4th of March by the World Obesity Federation on the global, they release a global data, and this is about the all three classes of BMI. That is, the data from overweight is excluded. So the projected prevalence in 2013, as far as India is concerned, although in adult men and women, the number might vary from 0.2 to 4.4%. But what is more baffling to know is about the projected prevalence in our kids and teens. With 5 to 9 age year group are expected to grow to around 12 million by 2013 at a percentage of 10.8, and those in the 10 to 19 year age group grow to 14 million at a percentage of 6.3% to 3% of the population. With these numbers, a health crisis in India may soon be fueled. So this is not because of the only because of the obesity, but the associated high numbers of comorbidities. So as per literature, existing literature, the class 2 obesity at the age of 18 independently carries an increased risk of severe walking limitation by more than 300%, normal kidney function again by more than 300%, polycystic ovarian syndrome in female by 74%, asthma by 48%, diabetes by 42%, obstructive sleep apnea by 25%, and hypertension also by varying degrees. Although other studies have also reported on the relative risk of the pulmonary complications in adolescent obese at 1.52%, whereas that of odds ratio of having a musculoskeletal injury in such kids at 4.5. And another study also reported the existing incidence of non-alcoholic fatty liver disease in adolescent obese is 62.5%. So when you translate these into the mortality, again the burden is enormous, especially in syndromic forms of obesity. According to literature, there are more than 100 syndromic conditions where obesity is a component, and more than half of those are still unnamed. The commonest being the Prader-Willi syndrome, which is very common. And as per the literature and the 40-year results have been recently published by the American study, they found the risk is 20 times higher than the general population. And majority of these kids die either in adolescent or early adulthood, with an average age of 29.5 years. And the commonest cause being the respiratory failure secondary to the obstructive sleep apnea, cardiac disease, the GI problems, which include perforation, obstruction, and these kids do have a component of hyperphagia underlying, and the pulmonary embolism because of the sheer obesity and the restrictive mobility. As far as non-syndromic forms of obesity, adolescent obesity is concerned, they found that adjusted hazards ratio for all-cause mortality is dependent on the duration of obesity in years. And the hazards ratio is 1.51 for the duration of less than 5 years, and it increases to 2.52 for duration more than 25 years. And the same study also quoted the risk of mortality only due to the cardiovascular disease increases by 6 to 7% for every 2 years lived with obesity. What interventions we can plan for these kids or these adolescents with morbid obesity? In general, obviously, the first line approach is by an intensive age appropriate family centric modifications, whether it's a form of dietary modification, excessive physical activity, behavioral modification, or we can add into that the medical management in the form of anti-obesity drugs. Although there are many obesity drugs are there, anti-obesity drugs are there, but there are only few which have been approved by FDA for adolescent age group. With Orlistat approved for adolescent more than 12 years of age, and there are numerous trials with study duration of around 1 year, and they have found that percentage total weight loss is in the range of 4.6% compared to 1.7% of placebo, and only less than half of these kids have been benefited by or patients been benefited by Orlistat, which is a lipase inhibitor. When it looks at other drugs approved in adolescent is the phentermine topiramate combination, although approved for adolescent more than 16 years of age. And again, the results were not that good at 8.5% of the total weight loss compared to 1.7% placebo. The other drug approved in adolescent is the liraglutide GLP-1 analog. But again, the results are, you can see that less than 10%, 7.1% compared to the placebo of 1.7%. While other drugs have been approved for adult population, but like locarcinin was recently withdrawn by FDA for its cardiac valvulopathic complication. Another interesting drug which is recently approved by FDA in 2020 for children 6 years and older with specific genetic confirmed obesity related, like in 3 specific conditions of pro-opiomelanocortin deficiency, the leptin receptor deficiency, and the proprotein convertase 1 deficiency. And it's a novel MC4R agonist which acts in the hypothalamus and reduces food intake and increases the energy expenditure. So in twin studies where they have follow-up of 1 year, where the kids have undergone daily injection of setmelanotide for 48 weeks. So the percentage weight loss was although more than 10%, the sample size in the range of 10 and 11 patients only, and around 46 to 80%. Like for specifically for POMC deficiency, they found that 8 out of those 10 patients even had a percentage total weight loss in the range of 20 to 25%. But for other deficiencies like leptin receptor, the results were not that good. With these, what about the other modalities like lifestyle modification? There's a study from our center only where we check the efficacy of comprehensive yoga program for weight reduction in overweight children. Although the mean BMI was in the range of 26.5, it's an open label randomized trial where the children of 8 to 15 years of age group were randomized to three groups, where the first group had a standard weight management of diet and physical activity. The second group had comprehensive yoga based management, whereas third was the no intervention group. And patients were assessed at the end of 4.5 months. The improvement in BMI in the first group was noted at the range of 1.4 kg per meter square. It was 1.2, whereas the control group in fact gained on the weight. But these improved numbers of BMI of which is quite minimal as per the overall genetic profile or obese profile of these patients. The percentage of patients who really benefited with these interventions ranges from 60 to 62% only. So looking at as a wholesome approach of these first line approaches, including the medical management, except for the setmelanotide, although the short-term results are there and long-term results will be weighted. So the benefits are of definite limitation. So here comes the role of bariatric and metabolic surgery. These patients especially, that has been proven as safe and effective in adolescent obesity, including the syndromic and the genetic forms. There are published and unpublished data available which has shown reasonable results in short-term and mid-term follow-up. This is a study from our center, from our team, where we have published the initial data of 10 patients, of them with having underlying syndromic obesity. All have underwent sleeve gastrectomy, and the percentage excess weight loss in the range of 41 to 60% at median follow-up of 1 year. Our current data is expanding to around 16 patients, with 6 of them are super obese and 6 having genetic or syndromic obesity underlying. And majority of patients underwent sleeve, and including the one patient we are discussing today who underwent re-sleeve as well, and rest of the patients underwent bypass procedures. Reported any immediate complication in the form of leak or bleeding. And on long term, we have noted a 75% resolution of their comorbidities in the form of diabetes and obstructive sleep apnea in the form 60%, 66%. Mean percentage excess weight loss at different duration of different phases of their life in the range of 58 to 60%. Although the results are slightly inferior in the syndromic patients. Coming to studies across the globe on adolescent population and their impact on weight loss, there are several studies which either looks at the impact of the gold standard Roux-en-Y gastric bypass or sleeve gastrectomy in these adolescents. But then there are studies also which compare the two techniques, and the mean improvement in BMI has been found from 13 to 15 kg per meter square, whereas the excess weight loss has been found in the range of 61 to 76% at short to mid-term follow-up of 2 to 4 years. As far as the impact on comorbidity is concerned, the one study which studied both the surgical approaches, they found that 95% resolution of diabetes in their set of cohorts, whereas another study which had a short sample size and even less follow-up, they found that there is significant improvement in the apnea hypopnea index of those patients with obstructive sleep apnea. Based on these studies and also the teen lab study, which is a longitudinal assessment of bariatric surgery in teen age group, the American Academy of Pediatrics issued a policy statement in December 2019, where they recommended the bariatric surgery in adolescent for the age group of 13 to 18 years, with those with class 2 obesity and with comorbidities, and those with class 3 obesity, that is BMI more than 40, without any comorbidities, should be recommended for bariatric surgery in this age group. Coming specifically to our topic, the genetic form of obesity, as we know that the syndromic forms are more common, more severe, but for the sake of today's talk, I'd like to limit myself for the monogenic form of melanocortin 4 receptor deficiency. But there are some certain red flag signs where we can differentiate the two, the syndromic and the monogenic form. The syndromic patients usually have early onset, they have associated dysformism, low IQ, short stature, delayed bone age, hypogonadism. Peculiar to monogenic obesity is that these kids have a component of hyperphagia, the food-seeking behavior, the associated lack of satiety, and the willingness to eat even the unpalatable food. In specific to the MC4R deficiency, the literature reported that it's one of the most common form of monogenic form of obesity, with up to 6% of cases has been reported in different studies. The more important to know is the leptin-melanocortin pathway, which is basically the fundamental to the energy homeostasis in the body, and it is because of the peripheral signals from the either the insulin on the leptin on the specific receptors after crossing the blood-brain barrier. They act on the pro-opiomelanocortin receptors in the arcuate nucleus, where this send strong satiety signals to the MC4R receptors located in the hypothalamus. The contrary, the expression of neurons like neuropeptide Y, the agouti-related peptide, uh, because of the peripheral action of the ghrelin or the peptide YY by different mechanisms, they strongly inhibit these signals of the MC4R. So any dysregulation of these pathways can cause alteration in the energy homeostasis, and the subsequent and those patients with genetic MC4R deficiency, especially those with homozygous, these patients have this altered pathways and have significant component of hyperphagia. So as far as studies specific to MC4R mutation is concerned, there is a study by Marisa et al., which is one of the earliest studies on MC4R mutation. They found that 5 of the 135 patients who were prospectively enrolled have MC4R mutation for bariatric surgery. Although only 4 patients opted for the bariatric procedure, 3 of them underwent gastric banding, another patient underwent sleeve resection. The 3 patients who underwent gastric banding have variable follow-up of ranging from 1 to 5 years, and the follow-up they have percentage excess weight loss ranging from 36 to 85%. Whereas that patient who underwent sleeve resection had excellent weight loss of 96% at 1 year. Another study by Kuhlman et al. Published in 2020 found that 3% of patients undergoing bariatric surgery had underlying genetic obesity with heterozygous mutations in MC4 and other genes. Those who underwent sleeve gastrectomy for specifically for with underlying MC4 mutation, they found that although the total percentage weight loss is significant compared to the baseline, but it was lower compared to the patients lacking a molecular diagnosis at a follow-up of 2 years. But the patients who underwent the gold standard Roux-en-Y gastric bypass procedure, the percentage total weight loss did not have any significant differences compared to those without molecular diagnosis. The same study, they found that 3 patients who underwent regional RYGB because of the weight regain. Those patients with mutation had significant weight loss at 2-year follow-up. Although our patient had some component of cirrhosis on second study, which made us change our plan, but our team has published data on the safety of bariatric surgery in both the non-alcoholic fatty liver disease as well as cirrhosis. Whereas we found that in a prospective study at 1-year follow-up that there is significant improvement in all the histopathological parameters of non-alcoholic fatty liver disease, and this is for all 3 forms of surgeries, whether sleeve gastrectomy or the gastric bypass. Whereas another meta-analysis published again by our team found that overall post-operative and liver-related complications were higher among patients with liver cirrhosis than in non-cirrhotic patients. This is related to 90-day mortality and morbidity. And they also found that sleeve gastrectomy showed lower post-operative complications compared with the Roux-en-Y gastric bypass when they underwent underlying cirrhosis. So coming back to our patient, this patient had significant reduction with maintenance of weight, especially after the second surgery, which provided the mortality benefit in the initial part because of the significant improvement in the comorbidities even after the first surgery. I did any particular quality of life assessment, but she is living a better quality of life and is very active in her daily life. Although on a darker side, she developed cirrhosis, which is again maybe cryptogenic, and she had that underlying, but is in a compensated stage with normal LFT and is on regular follow-up, us as well as Department of Gastroenterology. The take-two practice message from this study will say that, or this presentation can that adolescent with genetic forms or even with the syndromic form of obesity has very high rate of morbidity and mortality. Bariatric surgery has proven to have definitive benefits, especially in the early stage when they have very morbid obesity, that limitation of activity and associated comorbidities. So it's prudent to approach such patients in a multidisciplinary fashion so as to achieve optimal outcomes. And it's very important for these young adolescents to involve, for us to involve their families in the preoperative decision making and counseling. and to make them to ensure that they should understand that this bariatric surgery is a valuable weight loss adjunct rather than a cure for their underlying genetic obesity. So this is a message from last evening. We contacted this patient and she recorded an audio message on how she's doing at present. So I just like to play that audio clip. Now I'd like to invite Professor Sandeep Agarwal for his concluding words. Thank you, sir.
Thank you, Venu Arun. We presented this case firstly to highlight the important impact of bariatric surgery, which is far, far greater than many other options which are used consistently, and the bariatric surgery is used as the last option, although that should not be the case. And the second part is the revision surgery, which is very rarely reported. Remember, when we are also very skeptical about reoperating a patient because we know there are many issues which lead to weight regain. It's just not the anatomical factors. So we are not really reluctant, but I think the patient is very intelligent, very keen. The patient, they were very clear that they wanted resurgery. And in spite of cirrhosis, where we do find in about 5% of patients, we do find incidental cirrhosis in our patients. We have proven the safety and efficacy of bariatric surgery in cirrhotic patients. So this patient did extremely well, and in fact, far more than the expectations from what we expected. So this was just another thing so that we highlight the impact of bariatric surgery. I would like to invite Dr. Vandana Jain for a comment. She is a pediatric endocrinologist who deals with a lot with childhood obesity, and Dr. Shalimar, who helps us a lot in our program with NAFLD and cirrhotic related patients. So Dr. Vandana, thank you. Thank you.
So very nice case. So I think for me also it was a learning experience, because when we see pediatric patients with morbid obesity, so our main fear is that, okay, even if we do bariatric surgery once, they're going to regain in another 4 or 5 years, because we have had this experience, and then they come back and say, "Koi fayda to hua nahi ultimately." But I think this is really an eye opener that obviously, okay, even when you lose weight by other means, then also you have a tendency to regain. So same thing is happening here, and the sleeve can be done easily, probably revised easily. So that is one learning experience. Obviously, that child had a morbid obesity. She was in a very debilitated condition, and probably she would not have survived, I think, without, especially with patients with monogenic obesity. Actually, they have very early onset obesity, and in fact, we have seen more patients with leptin receptor defect. Them are very young till now. So with leptin receptor defect, typically the early onset hyperphagia starts at the age of 2-3 months, and by the age of 6-7 months, these babies are actually very, very obese, and they typically develop sleep apnea and other problems by the age of 2-3 years. So in those young patients also, probably some ultimately this kind of management would really help. Apart from that, of course, for children with exogenous obesity, that is nutritional excess obesity, for them, uh, unless the obesity is already at the stage where our dietary management is not going to work, diet and physical activity are really full. They work, provided that they have to be given by somebody with a very, very individualized approach, and it's like a life coach kind of a person who's actually motivating them at each step. If you just see them in the OPD and call them after 3 months, I'm sure nobody is going to lose any weight like that. But otherwise, it's we do see that many patients lose up to 15-20 kilos also. Children also, they lose weight very nicely. Prevention is obviously the best. So I don't know why the governments are silent. We keep on promoting all sort of unhealthy foods on TV, and then we tell the children don't eat this. So children are victims of an obesogenic environment. I think that is what it is. So government has to wake up to this crisis, I think.
Thank you. I think Dr. Shalimar will discuss. The cirrhosis actually improves. We have shown in multiple publications that cirrhosis improves. We're prudent with biopsy as well as fibroscan. But I think Dr. Shalimar will be able to throw more light. The cause of cirrhosis in this patient is not very clear.
So, before I answer your question, sir, one is that adding on to what ma'am said, say, when we see a patient and we ask him to lose 5% of weight loss, in my clinic, I'll see less than 5% of them achieving. So that low is the weight loss, or diet and exercise you're going to tell doesn't translate into any benefit. Benefit in the sense patients do not change their attitude. They do not take up this good practice of eating a healthy diet and doing exercise. Let me put a question out here. We are, as doctors, would be telling each of our patients to exercise. How many times do each one of us exercise? Do we really go? For a healthy individual, it is advised 45 minutes of exercise 5 times a week. I bet I won't find anyone in this room who will be doing that kind of exercise. That's the major problem. We don't practice what we preach. Non-alcoholic fatty liver disease is becoming or is the most common liver disease across the globe. We done a recent meta-analysis of all studies published in India. We find that 38% of adults, 35% of children in India from published literature have non-alcoholic fatty liver disease. Yeah, globally the percentage is 25%. It goes from country to country. Yeah, all children. You take the whole cohort sitting over here, I bet half of us will have fatty liver. You need to get it evaluated. Unfortunately, we don't get. And what reports we get from the radiology will say, okay, nothing's there. ये तो सबको होता है. That's our current usual mindset. Yeah. The other thing is in United States, where we have the most published data, the most common indication or which the fastest indication for getting a liver transplant is non-alcoholic fatty liver disease. We are just 10 years, 20 years behind them. We're having the same lifestyle. We are having the same dietary habits. We're getting more westernized. So it's just a matter of time. We'll just catch up with them. And it's becoming quite common. We are seeing a lot of complications these days. And this patient likely has non-alcoholic fatty liver disease leading to cirrhosis. Though she's a young child, but the way the weight is, the way the possible multiple factors. So non-alcoholic fatty liver is not just one factor playing in. There will be multiple factors playing in. Probably that has led to her cirrhosis. And we are seeing this disease quite frequently. The problem is that we don't see as gastroenterologists. More of these patients go to the cardiologist. You get young patients getting MI. They have more of MI. So to me, a patient will come when he's got cirrhosis. Prior to that, he's going to the endocrinologist, he's going to the gynecologist for his diabetes, PCOD, cardiologist for his MI. So these are the other complications which are responsible for deaths of these patients. But we see only a very small fraction with liver disease. That's the end stage of the spectrum. But it's very common, sir. Progression in non-alcoholic fatty liver disease as compared to viral illness is very different, sir. Non-alcoholic fatty liver disease is a very slow progressive disease. To say, like when we grade, as you know, you being a pathologist, you know, we grade fibrosis as from 0 to 4. 0 being no fibrosis and F4 being cirrhosis. So to move from one stage to another, it takes 15 years for a patient with pure non-alcoholic fatty liver disease. There is a term what we called as NASH, which is non-alcoholic steatohepatitis. There's a lot of inflammation going on in the liver. Over there, the stage progression is 7 years. So this data is based on 7 years to move from one stage to another. So NASH patients progress more quickly. This is based on a paired biopsy meta-analysis data, predominantly from Western literature.
Just to add to that is that we find a 5% rate of cirrhosis in our bariatric surgical patient, incidental, all walking in with normal LFTs. And so we find them incidental. So it's such a big problem. So any other comments? Thank you, Dr. Shalimar. Any other comments? Yes, sir, lots of data. The surgery is there since 60s. So roughly, if you look at our own data of 10 years, most of the patients are maintaining a good excess weight loss of more than 50% excess weight loss. And obviously, there are failures to the 5 to 10% who regain a significant amount of weight. But overall, even those who have regained weight are still having a diabetes remission because there are hormonal mechanisms for that. So overall, this modality actually, there's no other modality which comes close to it. Issues are a lot of myths about bariatric surgery, and I've requested Dr. Vandana many times that we can develop a protocol. I attended a meeting in American Academy of Pediatrics. They discussed case studies when there was a lot of delay in offering bariatric surgery. So it's just that we need to make a protocol at what stage bariatric surgery should come in. I'm not saying it should be the first step, but at some stage, 6 months of non-surgical, it should be at least considered. So I'll say, so the nutrition deficiencies are more common in a bypass procedures which are malabsorptive. But if you look at our preoperative workup of these patients, 90% of them have already have vitamin D deficiency, vitamin B12 deficiency, and a lot of deficiencies. So I always say that this is now we in fact follow them up, we catch these deficiencies and treat them. So I think that's again a myth, over a long term. Well, thank you very much for patiently. Thank you, Dr. Arun Venu.